start, we're going to do gout today. All right, now there are a few graphic pictures later on, but I will prepare you before you see those. So, this lecture is actually meant to explain what gout is, right? We're going to go through the medications as well, those that we use for treatment, and also to explain why starting the medications is so important. Now, I want to emphasize that the lecture is meant to be educational. It is not a substitute for treating yourself as well. Now, you need to consult with your medical provider to discuss current medications, and of course, you need to take the prescribed medications under the direction of your physician as well. And you'll see when I go through the different medications that many of these are chosen on an individual basis, based on other medications you're on, based on your other medical problems as well. So that's why it's so important that even though we're going to go through all of this stuff, that you go to your primary care doctor. So this is gout. And a lot of patients will agree that this is how it feels, more like gout. So it's caused by deposition of these crystals known as monosodium uric crystals. And it comes from an elevated uric acid level in the blood. And uric acid is actually increased because of overproduction. It can also be caused by an impairment of the kidneys to actually remove it from the blood. Additionally, which wasn't mentioned in this small spot, but you'll see later on, it can actually be caused by genetic predisposition. Some patients just get it. So the inverse is that not everyone with a high uric acid develop gout as well. There may actually be individual differences between how one person responds to an increased uric acid level as opposed to the other. Some people are actually more susceptible to the inflammation, and therefore they have more joint pain as opposed to others. So, who is most at risk? Males, patients with advanced age, and a simple reason is because as you get older, the kidney filters out things differently. Now, this may seem counterintuitive. Initiation of allopurinol or Uric, which is the actual medication for gout. Now, I try to explain to patients that what happens is that when we first start the medications, you're trying to remove the uric acid. So sometimes what happens is that as there's a change in how the uric acid is being disposed of, it can actually induce a gout attack. Very odd, but yes, it does happen. And you'll see that sometimes when we start allopurinol, a rheumatologist, even your primary care, or even Uric, which is very similar to this, we start either prednisone, or we may start Colchris or colchicine, or even one of the NSAIDs like naproxen or one of those to prevent the gout attack, while the allopurinol is trying to lower the uric acid. So trauma, surgery can also cause it, starvation, fatty foods and overindulgence, and weight loss does decrease the risk of gout, dehydration, alcohol, particularly beer, and ingestion of certain drugs which actually increase uric acid. One example are the diuretics, for example, loop diuretics or thiazides, such as Lasix or hydrochlorothiazide, right? Low-dose aspirin sometimes, even insulin and the beta blockers. And the reason they do this is because they change how the kidney is able to get rid of the uric acid. One thing you must keep in mind, though, is that even though these medications cause this, we do not discourage the use of them. For example, if a patient has risk factors for cardiovascular disease and you have gout, sometimes it makes more sense to be on the aspirin, to be on the diuretic as well for blood pressure control, and then we just control the gout on the side. Now, some patients ask always, why is it the big toe that sometimes gets involved? And it's often related to the coolness and decreased solubility of the crystals in that area. That's why patients get gout in the big toe. Sometimes they think it's because of microtrauma, and some patients dissolve crystals in different ways. So that's why it tends to happen there. Now, There are different syndromes, and you'll see that some patients actually, they go in between these different phases rather. There's acute gout, which is of course the acute attack, which is extremely exquisitely painful. Then you also have an intercritical or interval period, and this is the period in between attacks. And hopefully this lasts indefinitely once you're on medication. Now here you'll see a very graphic picture of what are known as tophi. These are actually uric acid crystals that have actually deposited within the joints. And this is of course someone who has severe form of gout. And if you go untreated, or if you're not appropriately treated with enough medication, then this can actually happen, where you continue to have chronic recurrent accumulation of the uric acid and pain. So how does it present? All of you who have had gout attacks know it's severe, severe pain. One of the things we learned in medical school is that a patient can't even allow a bed sheet to even touch the foot, particularly when it happens. That's how severe the pain is. There is swelling, there's redness, there's disability. You can't move the joint. And usually it tends to have a maximum severity in about 12 to 24 hours. And gout actually does resolve by itself. But the reason we of course treat is because of that previous hand that I actually showed you. The tophi develop. It tends to resolve by itself because it's a crystal, so the body finds a way to actually dissolve it gradually. Now, 80% of initial attacks happen in the big toe, even the knee. It can happen in the hands, the wrists, elbows, ankles, all of these places, particularly if you're not treated and you continue to have more and more attacks. So, how does it look? So you'll see some patients actually, it can be very benign, right? Sometimes just one wrist, sometimes you just have a small tophi, which is that accumulation which I showed you, and this is the uric acid coming out. And then sometimes this is how bad it can happen. Yes, this is rare, but this is what it can progress to, and I've seen this in some patients. This here is of course severe gout and tophi, and here you actually see destruction of the bone caused by the uric acid entering these joints and just essentially just eating away at these areas over here. So what do we do when we see a patient? We do lab tests, of course, especially of course if in your hospital you get the white blood cell count. We do the ESR and the CRP, which shows if there's active inflammation. Some patients, however, have a normal uric acid. And the best time actually to get this done is about 2 weeks after the attack. So, the new ways of diagnosing gout, and we have new recommendations which I'll go through, but the best way to actually diagnose it is to get fluid from that painful joint and to look for the crystals. And I'll even show you what that looks like as well later on. The reason we actually emphasize that getting the fluid is so important because so many things can actually mimic gout, because you see how non-specific it can be. You can get just one wrist, it can be just one toe, it can be both knees, both wrists. Osteoarthritis, pseudogout, which is actually another joint disease caused by another crystal, can also present similarly. Rheumatoid arthritis, even infection and trauma can do the same. So, not to get you very confused, but this is one of the new criteria that we have for diagnosis. And you'll see, just very simply, that step one is, of course, that a patient should have at least one joint where you have swelling and pain. And then, of course, the sufficient criteria to make diagnosis is to get that fluid and to look under the microscope and look at the crystals. Here it just runs through the algorithm that physicians use now to actually diagnose. And I'll go through each of these as we continue. So this is the uric acid crystal. And it's so small, yet causes so much damage. And this is actually seen if you think of it, and I'll show you next picture later on. These are small white blood cells that you see here. So now you can think of how small these crystals are. But this is what causes all of that pain when this accumulates within the joint. So here you have it again, a patient with a tophi, and these are your uric acid crystals coming out, and these are all the little crystals coming out here. And this is a white blood cell to show you exactly how small these crystals are. Same thing, you have one wrist swollen, and these are the uric acid crystals that you see there. So there are many other ways to diagnose gout, but if you think of it, as time, all of these become more and more expensive. So that's why we always emphasize doing, of course, what we call the arthrocentesis, or the joint fluid aspiration. So here you'll see sometimes, if a patient has, if we're not quite sure of if it's gout or rheumatoid, we do an ultrasound of the joint. Here you actually see this double, so this is the normal bone. And here you see this line, which is actually uric acid, which is on top of the bone. And eventually, as time goes by, it causes these erosions and breakage in the bone. And that's what I showed in that previous x-ray where there was destruction. Now, this is picking up more speed as time goes by. This is dual energy CT. And this here is the uric acid crystal. Of course, as expected, this is a much more expensive test. And this is only done in those patients where there's a doubt or you're unable to get the fluid from the joint. X-rays are done, and here you'll see that there's a big bite out of the bone, a bite. And this is the destruction that the uric acid crystals do, right? They cause these erosions and these bites in the bone, and that's what causes severe pain and dysfunction as the years go by. So, treatment. Number one, lifestyle modification. We go through the medications, and I'll even show you a picture of a patient who actually had surgery as well. So, these are actually the recommendations that come from the ACR, which is our rheumatology governing board. And you'll see I'll go through each one here. Of course, the first thing they always advise is, of course, weight loss. Overall healthy diet, exercise, smoking cessation, staying well hydrated. Now, we'll go through each one. You should avoid organ meats high in purine content, liver, kidney, high fructose, corn syrup, sweetened sodas and beverages. Alcohol overuse in a male, more than 2 drinks, and a female, more than 1 drink a day. Any alcohol use during an actual attack. What to limit? Serving sizes of beef, lamb, pork, seafood as well. Servings of naturally sweet fruit juices, table sugar, and of course alcohol is what you should limit, as we said before. And then you want to encourage low-fat or non-fat dairy products and vegetables as well. So you see at the bottom here, in very, very small print, they talk about cherries and cherry products. They didn't really make a recommendation about it, but I have many, many patients who take cherry extract, and they do quite well. So I do still encourage it if it doesn't cause an increase in your blood sugar, if you have diabetes, it doesn't cause any other side effects. I still think there's no harm in actually using the cherry juice if it brings about some relief of the pain and prevents the attacks. So, when you're seen, your doctor actually needs to assess certain things, right? Now, in a young patient who gets gout, this is very strange, and your doctor or your rheumatologist should actually do a uric acid level. And we tell patients you actually have to collect a 24-hour urine estimation of it. Because some patients, actually, the kidneys, as we said before, are not able to filter it out properly. And if they're not doing that, there's a certain medication called probenecid, which actually can be very helpful in that case. We, of course, evaluate for obesity, excessive alcohol intake, diabetes, high blood pressure. We look at the different medications that you use for that. Uric acid elevating medications. And with respect to this, sometimes if a patient, for example, like what I said before, if they're on Lasix or they're on hydrochlorothiazide, if they're just using it for blood pressure, one thing that can be used is actually losartan or one of those other medications in that group, which actually causes the uric acid to be filtered out much better as opposed to using one of the diuretics. We asked about a history of urinary tract stones, because if that is present, the threshold for which we start medication is actually much lower. We asked about chronic kidney disease, and in select cases, of course, genetic causes of uric acid overproduction, and lead as well. So, treatment. What should you do when you have an attack? I always tell patients, ice. Ice, ice, ice. It actually really does help, right? You never stop your uric acid medication if you're already taking it when you have a gout attack. The problem, and the reason I raise this, is that sometimes when patients go into the hospital, it was thought that you should actually stop it, or you shouldn't in fact continue with your gout medication, or you shouldn't start. You should actually continue with it unchanged throughout an attack. And of course, you call your doctor. Now, what do you do if your doctor is not readily available? Let's say this happens on a Friday, after you have a shrimp cocktail and about 5 drinks. And of course, you can't get in contact with your doctor over the weekend. Now, I wrote this down because these, of course, are our recommendations as physicians. But you'll see that I put a disclaimer again that even though these are recommendations, you still should, if there's any doubt in your mind, you go to the emergency room. That is the most important thing. Now, you can use naproxen, which is a Aleve. There's indomethacin, there's Cilindac, which have all been approved for acute gout. Even Celebrex, celecoxib, is also a good option for some patients. You continue your initial treatment, as we said before. But this is what I wanted to mention. A lot of these medications can be harmful depending on your age, depending on what medical conditions you have. If you have kidney disease, stomach ulcers, previous bleeding, cardiovascular disease as well, particularly with Celebrex, other serious medical conditions. And that's why I still advise, despite knowing this in the background, is going to the emergency room if you have any doubts at all for further evaluation so that the correct medication can be chosen for you. One of the instances, for example, if a patient has severe kidney disease, but they only have one joint that's involved, just simply doing a steroid injection into that joint can actually help, as opposed to doing or starting medications that can cause more problems, like naproxen or one of them. So this is a somewhat complicated table, but just so you know why we always run through certain algorithms. So if, of course, you have a severe gout attack, of course, the NSAIDs, which is what we described before, which is the naproxen, and a COX-2 is Celebrex. Sometimes your doctor may actually give you steroids, depending on what medical conditions you have. If you can't tolerate the NSAIDs, colchicine is often started as well, right? You'll see the ice is here as well. Now, I just brought this up as well to show that some patients may never actually respond well to these, and there are several off-label therapies that are used, but these are very expensive, so that's why we start off with these first. Now, just very briefly, I just wanted to discuss the medications so you understand why it's important to be on them. Now, allopurinol and febuxostat, right? they work at this point to prevent the production of the uric acid, right? Now, one thing patients always ask, why can I just not do diet control? And the reason is these are just normal metabolites or breakdown products that come from everyday living. And no matter how you try and restrict alcohol, certain foods, this is going to be produced despite what you do. And this is your uric acid. You'll see febuxostat or Uric and allopurinol here. It stops the production of the uric acid. I'm going to highlight this particular enzyme here, which converts uric acid into allantoin, which just gets excreted in your urine, because they have a new medication which is a relative of this that we use if these don't work in patients. So the dose of allopurinol has to be chosen based on your kidney function, your other medical problems, and after reviewing your medications as well to ensure that there's no interaction. There can be very rare but serious consequences if allopurinol is not started at the appropriate dose. There's an entity called allopurinol hypersensitivity syndrome, where you can actually get very severe rash if you start the allopurinol at too high a dose, and it has to be tailored to your kidney function. The same applies to febuxostat. We like febuxostat actually more than allopurinol because studies have shown recently that the febuxostat actually does work better than allopurinol in patients with kidney disease. But the problem is that most often insurance companies don't pay for it because it is more expensive. So often you'll see we will try a dose of the allopurinol, and then if that doesn't work, then we move on to the febuxostat. Colchicine, as I said before, is started at the time that allopurinol or febuxostat is started to prevent an attack. What the colchicine does is it goes into the joint, it goes into the cell, and it prevents the uric acid from triggering off an inflammatory response. And that's why we start both of them together. So often what I do is, for example, colchicine. If I see you today, I start the colchicine, and probably once you're on it for a few days, then I add on the allopurinol so that I can prevent an attack from being induced by the allopurinol. Now, the other thing too is that colchicine has to be tailored towards your kidney function as well and your other medications, because this can cause diarrhea as well as abdominal cramping. Probenecid is that drug that I had discussed before, which is why we do the 24-hour urine uric acid. But this has to be selected according to certain patients as well. And of course, screening has to be done by a physician. So what can be done if these medications do not work? There's a drug that we discussed, which is pegloticase. It is given as an infusion, so you have to come actually to the chemo center, to the infusion center, and you get this every 2 weeks. It is extremely expensive, tens of thousands of dollars. So it's only reserved for those patients who don't respond well to the febuxostat or to the allopurinol. So one of the last things I'll talk about is actually surgery. And I've had patients who've had this actually done by the hand surgeons. And it's when you have those tophi that just refuse to go despite medication. They cause severe dysfunction. You can't use your joints because of how big and bulky they are. It can be removed, right? But the problem is you have to be carefully selected for this as well, because sometimes after surgery, the area may not heal as well. But this is one example, and here you see that they're actually taking out the tophi, and this is all sodium crystals just accumulated in the area. So, as I always advise, if you have any concerns about your joints, about gout, see your primary care doctor, let them evaluate. Gout is very manageable, right? Your primary care doctor can actually do most of this, right? But if it's difficult to control, the uric acid is not going down, of course, referral to a rheumatologist is appropriate. One last thing I realized I didn't quite include here is a lot of my patients actually, they follow the uric acid level, and they always ask, what is the appropriate level? If you have tophi, which are those accumulations, your uric acid should be less than 5. If you do not have the tophi, then we allow for 6. That's the recommendations that we have now. All right? Thank you. Any questions?
What is carpal tunnel? Is that connected to gout, carpal tunnel?
No, it isn't. No. Yes?
How about the drug Voltaren?
So the question was, what about the drug Voltaren? Voltaren is good. It wasn't approved by the FDA for gout, but it is good because it's diclofenac. It's one of the NSAIDs, and it can be used for gout. But again, it would always be best to make sure that your doctor has to, of course, check to make sure your kidney function is normal before he prescribes it. But it can work just as well as naproxen and Cilindac. I'm sorry, I think I will go with him first, yeah.
Are there different kinds of gout?
There's only one gout, one type? And what do you mean? I'm so sorry.
Well, I had gout earlier with that wind, and then I got it again. He had some back surgery, and it's really kind of bad, and it doesn't seem to go away. And I was told there was different kinds, and I did take allopurinol, and I didn't get enough to do with that. I had 300 milligrams, and I was in the hospital for 10 days.
So
I don't know what's going to turn out.
So the question was, are there different types of gout, and what do you do if you're on allopurinol and you still end up in the hospital? So I think one misconception is that, as silly as it sounds, allopurinol comes in 100 milligram tablets and 300 milligram tablets. Some physicians only go up to 300. However, the recommendation from the FDA and even from the ACR or body is that you can go up to 800 milligrams of allopurinol. And I think a lot of physicians are afraid to keep going up, but you're allowed to go up. And I think what often happens is that a lot of doctors are like, oh, I don't know if I want to go up above the 300. And they don't often tailor the allopurinol to the uric acid level. So do you know what your uric acid level was?
I had it taken, but I can't tell you that. It was high.
It was high. That's the thing. The allopurinol should have been increased.
It wouldn't have been good. I was not good. That's what it was. The allopurinol.
Oh, it was causing side effects?
Yes, I had terrible side effects.
Oh, then we would switch to the febuxostat then, which is the Uric.
How long before you decided you got to do something different? I had this quite a while.
Well, we have no actual specific recommendations on how long, but I would give it maybe even up to 6 weeks to 8 weeks. Recheck the uric acid. If you have severe side effects occurring with it that are disabling, I would switch the medication.
Yeah, this has been since October.
Then I would definitely switch.
Are gout attacks brought on by exercise, like walking and stuff like that?
Honestly, it can be, especially if you become dehydrated. A lot of patients, if they go out gardening or they go out exercising and don't hydrate properly, it can happen. But the actual physical activity of it, no. It's because of dehydration most often. That's why it happens. Because the fluid shifts, if you think of it, it's just like any crystal, salt. If you don't hydrate, the crystals they precipitate and they trigger off a gout attack.
Is it strictly limited to joints, or can it happen like in shins or forearms or anywhere else?
It can happen anywhere. I did not show that picture, but I had one. I have a very graphic picture that I show the residents actually. Gout can go anywhere. The uric acid can go into the heart valves, it can go into the kidney, it can go into fat tissue, it can go anywhere, honestly. And the tophi can actually deposit anywhere. It can go on the shin, so usually when I examine patients, I look everywhere for it.
Who's going first? Okay, I guess in reference to the gentleman's question to my right, I think one of the concerns that we all have are the side effects. You watch television today and everything is medication. My concern is that it looks, in a lot of cases, it's almost better not to take the medication. Can you talk a little bit more about the side effects? And I've had some attacks where, and I did not continue taking the allopurinol or whatever. I still have recurring attacks, but I've been fortunate at times when I had them. The steroids worked quite well for me. And again, being very concerned about the side effects.
So side effects of the allopurinol, you can get the rash. It can cause, there's the rash, it can cause nausea, vomiting. It can cause, oddly enough, muscle pain as well. The colchicine can also cause similar side effects. I guess this is one of the things where your physician has to evaluate you, and then you have to individually, that's the whole thing about medicine too. Even though we have guidelines, you have to tailor prescribing medications based on the patient. Each patient has a different genetic makeup, how they respond to medication. I honestly would say if the attacks happen once a year and you have severe side effects with allopurinol, even Uric, maybe taking that prednisone taper once a year, even twice a year, may actually be a better option for you. Does that help in a certain regard?
The tapering worked extremely well with a couple of times I had attacks.
That is why, yeah, it's one of the things that we have in acute gout attack in that algorithm, I'm so sorry, that I had showed before. So this one, yeah. Not there. Okay. The steroids, you'll see there's actually a class A recommendation. It is allowed. The only reason we don't often use steroid every single attack is, of course, it has side effects, right? Patients who, because one of the things too you'll realize, gout does happen in older patients. They tend to have diabetes, tend to have high blood pressure. And this is the reason why we don't recommend always using it for every single attack. The best option is to prevent the attack. But again, it has to be, medication has to be prescribed on an individualized basis.
Can you talk a little bit about if you eat sardines or asparagus, how harmful that could be?
It can, so these are actually high in purines, and that's why they actually say that you should limit it. Where was that? Do they have, yeah, they actually have sardines here. They don't have asparagus, but you should limit the amount that you actually eat.
Concerning allopurinol, if you have a history of kidney stones, is that considered kidney disease? And the other question is, concerns allopurinol. I've read many, many times that allopurinol can be a problem because it does take the pain away, but the continuation of the damage to the joint continues. Two questions.
Two questions. So one, I'm so sorry. So the first one, just so I clarify, the first question was, does kidney disease, is it equivalent to kidney stones? No. Kidney stones tend to happen within the ducts itself. The kidney disease that I'm referring to is actually within the actual tissue of the kidney, and it's reflected in your blood results. Now on to the other thing, continuing uric acid, if you continue allopurinol, right? I'm so sorry, can you just repeat the second question? I got lost on the first.
I've read in several places that allopurinol does reduce the pain, takes the pain away, and lowers some of the uric acid level.
Right.
Not all of it, and you can continue to have joint damage because it now masks the pain, and so it can be very dangerous.
I would disagree because the allopurinol should actually decrease the uric acid, and that will be reflected in your labs. And once that actually gets down to the levels, the target levels that we had discussed, there shouldn't continue to be any joint damage. You can have joint damage if the gout was occurring for a long period and then you have secondary osteoarthritis and joint disease from that. But the allopurinol being present should prevent any further joint damage.
Is allopurinol safe for continued use long-term?
It is actually recommended to be lifelong.
Can allopurinol affect how your blood pressure medicine works?
It generally, usually I have to check because there's so many new ones that we have, but honestly, no. Go ahead.
If you have a sensitive stomach and you have gout attacks, in your opinion, what is the best thing to take as far as a drug? If you have a sensitive stomach.
If it's one joint that's being affected, then your doctor may actually just consider doing a corticosteroid injection into that joint. Because the colchicine can cause abdominal cramping, the NSAIDs can cause bleeding and ulcers. The allopurinol, not so much so, but if you have an acute attack, maybe just doing a steroid injection to the joint might be most helpful.
So the pseudo-gout is caused by a different acid?
By a different crystal, yes. So, yeah.
So does it have the same effect on the body as these other pictures that we've seen?
So pseudo-gout, not as quite, but it doesn't cause tophi as what you saw here because it's caused by a different crystal, CPPD, which is actually a calcium crystal. And what pseudo-gout tends to do is it accumulates in the joints. It can cause destruction, but the problem is that pseudo-gout is caused by different things. It's thought to be caused by hypoparathyroidism when your parathyroid is too high, by different things. And the whole mechanism behind this is that you should actually treat the disease that's causing pseudo-gout. We may use colchicine in some patients, but it does allopurinol, febuxostat, all of those don't actually work to get rid of that particular crystal because it's a calcium crystal, and they think that different hormonal changes cause the crystal to accumulate. So that's why you treat the disease that's actually causing the calcium to be deposited. CBBD crystals, yeah.
How often can you get the steroid per year or anything like that
Into the joint?
into the joint?
The recommendation is that you should only get it done every 3 to 4 months. So honestly, in a lifetime, 3 to 4 times into that particular joint.
When I have a flare-up with my gout, I take Indocin, I think I'm saying that right. And usually like 2 tablets over 24 hours, then it's gone. Is that enough? I mean, it gets to, after two of them, I can walk on it again and everything. I mean, it might be a little sore, but
Yeah.
it's not like it was.
What was that called?
It's 2 tablets
Indocid.
Yeah.
Indocid. Or indomethacin. It's one of the oldest ones that they have around.
I know my doctor recommends I don't take a lot of it.
Yeah, because it can affect the kidneys if you take too much of it for too long. Is it good enough? I mean, if it helps with the attack and it gets rid of it, yes, but not too often and not too long.
What I did is I was taking allopurinol and I thought my blood pressure was going up, so I stopped taking it on my own, and like within a month, I got it
It
back.
came back.
So I went back on the allopurinol, but I took 2 of the Indocin, and that seemed like it was enough to get by. And she talked about, we've been drinking cherry juice constantly.
All right.
But it's, yeah.
I've heard some weird stuff since people knew that I was going to do this. I probably shouldn't mention it. Some people say baking soda, all these strange things, but I do not recommend that. But the cherry juice, I've seen it. Yeah, and it tastes good. Any other questions?
The next class that's offered at Niles Hospital, is this going to be?
It's the same thing, yeah. Same one.
Okay, I didn't know if it was a continuation or.
I mean, I could have. It's in 3 weeks. What else would you all like to hear about?
I didn't know.
It was the same thing. They just wanted me to go, 2 different locations for everybody to hear about it.
Is there a place to get this chart?
This one, we can print it, and
We have your emails back there. We might be able to.
yeah, just send it. Well, I'm so sorry. I give all my patients this because I have multiple. I should have actually walked with it, but no, this was actually cut and pasted.
Well, do you have this at the office? We can
I do have it at the
office.
office. Yeah, I do have it.
If you want to come to our office.
How about this? Anyone that's interested, can stop in the back and I can give you my card. And Dr. Ramessar can send it, or I can send it to anyone that takes my card. How does that sound? Because I have your PowerPoint.
Okay, perfect. Yeah.
Okay. So if you're interested, stop and get my card. Okay? Okay. That work? For her PowerPoint slide, if you're interested in it? Yep.
Can we too get a list of vegetables on what we can eat, what is allowed, what's not allowed?
That's a good question. I will work on that. Okay, done.
Also, I just want to mention, there's an evaluation. In
Sorry.
the bag too, if you don't mind filling that out for us and giving some feedback, that's really helpful for us and Dr. Ramessar, we would appreciate it. You can just leave it at the table too.
Yeah, leave feedback, and if anything, I can always include more details in my next presentation at the end of the month. All right, thank you.